hopefully you're gonna have a good Tuesday for whoever it's in Asia and all over the world. I'm sorry that in Tel Aviv right now it's 3 o'clock in the morning, but I have a really nice team behind me, or better, I'm a little part of this great team that it's called Dayton Dental. They are great people with great minds, and they help us all out as doctors to develop something and give me the opportunity to show you guys something. So what we're going to talk about today, it's basically a membrane stabilization technique, all right? That raised a lot of concern back in the days because of mobility under the flap and dehiscence and suture dehiscence of the wound after like some graft procedures, for example. All right. And specifically with these materials that we use, and it's not new for you guys, for me, that I'm going to be showing a lot of O6 Plus and O6 products here today. I'm a big fan since a long time ago. You guys saw me a little bit of my background there. When I was in Michigan, I had the pleasure, I went there to get to know and to get to learn from Dr. Kalmesh, the first biggest genius that we had in the modern dentistry, in the modern implant dentistry. And I end up like working with two really intelligent and great professionals in our area that they are called Dr. Rodrigo Neiva and Dr. William Ginobili. They gave me the opportunity to kind of shadow them in a clinical trial and be part of it, another one. And I was there helping them out and everything. And back in the days, I was part of this study that was for a material called O6, not the O6 Plus, the first O6 that was in the market after it was out of the market for like 6 years. And then it came back as O6 Plus. Really way better, but it was not bad back in the days. And after we tried that so much, I went to Florida, like 6 years after practicing oral surgery in Brazil. I wanted to do the big procedures, and I did. And then after, I ended up in Florida because life took me there somehow. We don't have the time for me to tell you the story, maybe one day. But and then I got an implant fellowship and a contract with Dentsply, all right? And after I graduated, Dentsply and Dayton Dental, Dentsply and O6, they got together, they merged. So the two big companies that I was somehow helping them out, and they were helping me out, I was a little part of it. They merged, and here I am, blessed about the opportunity to be talking about the products because I'm a big fan of it. So the thing that I want to really tell you, the real big message that I want to tell you right now is the fact that I was a fan first, and then they invited me to show what I have done. And it's not the other way around. Oh, this guy does well, and we are going to hire him to talk about our products. And now, from now on, we are only going to talk about our products. So it's the other way around. So if I tell you about how good these products are, it's hard and it's not just business. All right. So let's put this case here as an introduction. I don't like introduction, theoretical one, history of membrane stabilization, tacking, and sausage technique, and whatever you want to. You already heard that. We are going to go straight to the technique. I want to optimize your time, all right? And I'm going to start showing right now. So I have this case, all right? A little defect of this molar, and the back molar had to go. Big furcation lesion, with nothing that we could do to save it. So it was non-restorable already. So I went there, did by the book, all the extraction, and we had this big defect on the mesial and everything. And I wanted to do like the site preservation, but I wanted to increase a little bit the defect that we had on the buccal of the first molar here, right? So I had to combine two techniques. I had to go there and do this lasso technique with a site preservation, with a socket preservation, call it the way you want it. I prefer implant site preservation because we don't preserve the socket. We actually preserve the implant site. If you preserve the socket, it's like if you would not allow the socket to heal, but you actually improve the healing of the socket. You get better bone quality if we do something there. And I did some bone grafting right in the front to get rid of that buccal defect that we had there. And I was expecting, okay, I'm gonna try my best to get primary closure here. That's quite challenging, but we do that all the time and we can do that. But I was not expecting, I told the patient that this socket would actually heal with a secondary intention, because I would be expecting some degree of opening, or the whole opening of the back part of it. As much as I could keep the socket like closed with primary closure would be the better, would be best for my graft. But I would expect like 1 week of closure, maybe 5-6 days, and that would start like opening. 2 weeks later, and we had just that. A little bit of closure, maybe it was not even like a dehiscence per se. That was just maybe just a little opening of one of the sutures, but the flap was too big. How did that happen? All right, how did that happen? And that little opening there was already granulating in the bottom. So how did that happen? No exposure of that socket. Primary closure, of course, periosteal release, everything that we do, it's very nice. But one thing that we have to learn and to accept is the lack of mobility under your sutures, under your flap, is detrimental for the success of your graft. We cannot expect, all right, whoever works with periodontics like I do now, and or whoever works with implant dentistry. Sometimes we open a flap on an implant because we are placing an implant right next to it, or because we are cleaning a little bit that implant, it's kind of ailing. You cannot expect that flap to have any kind of attachment, even if it's a weak attachment, all right? Even if it's just the blood clot under the flap, that it's gonna stabilize that a little bit, some fibrin underneath. You cannot expect that flap to be stable and to not open if you have micro movements on it. It does not happen like that, all right? So everything under our flap needs to be stable and solid, all right, and tight, so you can have peace of mind when you go to sleep. And when that patient that you did the graft calls your office like 3 or 4 days after the graft, and you don't have like butterflies in your stomach because you think that everything is open, you're going to be pretty confident about your technique. Because just going there, imagine you open your mandible, just putting graft and throwing some membrane on top of it and closing the flap on top of it. First of all, your graft is going to go all over the place if you don't confine that where you really want it, all right? That's going to happen for sure. So this is what we had before. And this is what we end up like getting. So this is not what it's going to happen if you don't stabilize, all right? Your graft is going to be all over the place. A lot of bone particles are going to escape under the membrane. It's going to get trapped into your periosteum. A lot of pain, a lot of mobility there. So we are going to go for this technique step by step, all right? I already figured it out that it's not the same thing as if I'm right there with you, right next to your shoulder when you're doing your surgery, or even on a hands-on, and I'm gonna tell you the inclination of the needle and the sutures and how we're gonna do your incision. I'm gonna try my best to give all the tricks that it's gonna come to my mind right here, but there are too many, all right? There are too many. I would need like 3-4 hours with everybody to kind of give you like the best idea possible, all right? I started learning and I started figuring out how to teach that with Dr. Neva, and he had like so many hands-on through the years, and that was challenging for them to get the point. So I have seen a lot of feedbacks of how people actually learn that. But if you do anything similar and if you can improve your technique a little bit, and the technique has improved, I'm going to show you a case from a really good doctor, Dr. Kim, and you're going to see how he already improved the technique. So let's go for the technique. Let's go for that. Pay attention on these mandible here, all right? We go there and we do the perforations. A lot of people don't like to do the perforations. And I don't have a fixed opinion if that works or not, these little perforations, because I forgot to do it already and it worked perfectly. So I don't know if it's really necessary. It makes me feel better to have some bleeding there, but sometimes I forgot to do it and it's just fine. What I want you guys to pay attention there, it's in the bottom. You guys don't see my mouse here. So you are gonna have to follow my thoughts here. We have the periosteum right in the bottom, all right? And that's very important where you're gonna do that periosteal release. Keep that in mind. That's very, very important. And that's the main point that we are going to do. One thing that I want you guys to pay attention on this slide, two things. It's the one, the lingual flap, the one that the little periosteal elevator is retracting on the top. All the sutures are underneath that flap, all right? They are not going over the incision line. They are not going inside out from the flap. Everything's under the flap, all right? And the other thing, it's on the buccal right now. Take a look on that periosteum, how the membrane is stuck in under the periosteum, and we are gonna go back to that, all right? So let's go, this is just the closure, and now I'm gonna show you the healing. It's not fun if I show you perfect healings, because a lot of times we get perfect healings, but at least all my cases here, there's always a point that I want to show you guys. And this is the point for this picture right here. Not a perfect healing. Not at all. It's very challenging. This area is very challenging, all right? A lot of muscle pulling. And so sometimes I take it easy on the periosteal release because there's a lot of morbidity, a lot of bleeding. If I feel confident about the lasso, I don't do as much periosteal release as I was doing before because of the lasso technique. Not saying that you should not do it, you have to do it, but you just don't go crazy on it, all right? You start manipulating your periosteum way better, and you start minimizing the trauma to the connective tissue, doing that release on the buccal or even on the lingual. Of course, you don't use a blade on the lingual, but we do that retraction, that blunt dissection from the lingual flap. That's not new. People are doing that for a long, long time. Head and neck surgeons, they do that for a long time. So this is what you got even after. The only thing that I had to do there is just to keep it clean. If everything is solid and stable underneath, you are not gonna go down the hill, even if your sutures have like some opening. It's not a big deal at all. If you use these materials, all right? So this is just the finishing that case that I will showing you guys. And now we are gonna talk about the periosteal release, and we are gonna take our time here a little bit to actually start showing the technique. I don't wanna just show cases and everything and just throw everything there without going step by step, how we should do it. This is a pig jaw lab that we used to do, and we took our time and we did these videos. This was done back in Florida. So the periosteal release that I was talking to you guys, it's very important now, where you're gonna do it. Well, whoever it's already used to do these surgeries and do periosteal release, we have a tendency, and I had the tendency, every time you open up the flap, you go all the way down, as apical as you can go, and then you do the periosteal release really, really down there, all right? Now you should not do that anymore. It doesn't make that much difference. It doesn't have to be down there, all right? The height that we are gonna do our periosteal release is exactly where you want your graft to end. You don't want your graft to go all the way down to the base of the mandible. There's no need for that. You are gonna need the graft to be confined to the first 10 or 12 millimeters from the crest, all right? So right there, 12 millimeters from the top of the crest, from that knife edge that you have, you are gonna do that periosteal release right there, because you're gonna leave a little pouch. Can you see my mouse? Hopefully. We're gonna leave that little periosteal pouch in the bottom right here. All right, we're gonna stop doing that down there. Down there is gonna bleed even more because there's a lot of connective tissue. The flap is way thicker, so it's very easy for us to go with the blade and incise a little deeper than you actually have to incise. We're gonna go right there with a sharp knife edge, with a sharp knife, and you're gonna release that periosteum. You don't have to go more than once. Usually we see if we have the mobility, you keep going. You don't have to keep like cutting a lot of times in the same spot. As soon as you go beyond the periosteum, everything should be blood dissected. All right, you get the periosteal elevator, and you can pull that a little bit the same way that we do on the lingual. Stop using too much your blade on the buckle. All right, how much time we have to. I talk too much sometimes. So now we are going to have the membrane positioning. We did our periosteal pouch. And one thing that I do, and the Dayton guys, the Dayton dental guys, the Ossex inventors, they give me like the quits. They don't like that I say that, but I like to place my membrane on the lingual first, and I place the membrane completely dry. And they almost killed me when I started saying that. But then one engineer told me, there's no problem. As soon as he dried it, I do accept it. And that's what I do now. I have always done. So I put the membrane because it's just easier to tuck it in on the lingual when it's already dry. It's just harder, and it just goes, it slides. I just open the flap on the lingual and I put it there and I leave it there. All right. After, let me put it like this. What we are going to try to do is to place the membrane and tuck it under that periosteal pouch. Can you see that it's right there, right the same height that you have your membrane? You're going to be able to tuck it under the periosteal pouch. Because one thing that a lot of people never talked about, this is the case that it's very nice. One of the things that people never talk about is about the apical portion of the graft. People used to open up onto the base of the mandible, like for example, in the bottom arch, to the base of the membrane. They pack a lot of bone, they put the membrane, and the membrane is just flying on top of bone without anything underneath that graft. What do you think is going to happen with that graft? There's gravity, and there's things like there's tongue, there is mastication. Everything's going to pull that graft to the apical part, exactly where you don't need your graft, right? We need all the way on the top where the ridge is very thin, and the cervical of the implant is going to be exposed, and it always is. So we need that graft to be confined up there. So that periosteal pouch where you're going to tuck in that membrane, it's going to be very important. And this is the improvement that I told you about. Let me go about the technique. This is from a very nice doctor that I got to know because of these webinars that we do, and we share like some cases, and I have the community. Right now, I'm the leader of the clinical research community of Ossex, and you get to know a lot of good people, and you get to share, and you get to see a lot of good cases. So what he did, of course, the sutures are very nicely done, and the Ossex Plus here is very nicely shaped, and the picture looks great. But the coolest part was this horizontal incision in the bottom. Can you see it? He did not tuck under the periosteal pouch, but he figured out a way to confine his graft, and it's completely fine. What I'm gonna share with you guys today, it's a concept, it's a concern that I have about where your graft is gonna end up going. And he came up with this. He told me, Fred, I can only do that when I do the two verticals, because probably then he has like periosteum on the lateral part. So he engages the periosteum, and look how great that looks. I'm gonna try the next time that I'm gonna do in this position, I'm gonna open up right before I do the procedure, and I'm gonna try that. Even if I have my periosteal pouch, tuck it in, I'm gonna try to put like some suture there to try to make it a little, even a little tighter. That my periosteal pouch. I really liked, and this is the whole case that he sent me, and I wanted to share with you guys. It looks great. Look at the horizontal suture in the bottom, confining and holding everything up. And he showed me the results. And I'm a big fan of that because all the people that are sharing things on Instagram, but he posts the results and the implants placed. Because 99% of the posts that you guys see, the last picture is just the suture during the procedure. So I want to see the results. The results are very important. All right. So let's do the grafted position here. I already gave you guys a hint of what my concern is, right? One thing that I'm always concerned here, we are going to place like in layers because we used to do like sandwich technique from mesh. Now we don't do that anymore. I don't think there's too much difference, but we used to have like a canthus bone in the bottom with a fast resorption and then like a xenograft or a cortical bone on the top. Of course, if are going to open more than one vial of bone, it is still a good concept to work. But I don't think you have to waste bone because of that. And one thing that I want to be concerned about it's where this bone is going to end up going. So you cannot give, I keep telling my residents, don't give the final shape of your graft right at during the placement, the graft placement. You have to figure out where is this graft gonna go when I put down this membrane and I close the flap and I suture the membrane and I stabilize the membrane and then I suture my flap. Where is that going? If you already put it in place, it's gonna be flatter than you actually do because you're gonna apply some pressure. You're gonna do the first suture, you're gonna pack things up a little bit more, then you go for more suture, you pack things up a little bit more. After you are completely done, then you can leave it alone, but you're gonna have to adjust that a lot. So just keep it in mind. I always like to confine right in the middle, and when I'm placing the membrane, I keep shaping and I keep noticing that the graft keeps spreading, and then I put it in place and I do the last like lateral sutures, and then I keep going. All right. Membrane stabilization, the real deal right now. So how do we start? Here is not very easy to do it. Big jaws are dry and they are not as easy to do. But yes, the first suture that you should do, you should get that periosteal pouch that you did, all right? And one thing that it's very, very important. Remember the introduction case that I showed to you guys? I wanted to show you the periosteal pouch, and on the top with that periosteal elevator retraction, everything was going under the lingual flap. That's an honest mistake. I've been doing that for years and years and years, and I still make that mistake if I'm like too relaxed when I'm suturing. But sometimes you're just, oh, I'm about to finish, so you let down your guard a little bit, and sometimes I still do that. So this is what you have to do. You have to go in and out on the lingual side, and you have to go back in. Right now, you don't go here to the buccal again and you close the notch. You have to go back into the lingual flap the way we are going to do it right now. You get the flap, you're going to get the flap, and you're going to go back in. So everything is going to be internal. When you close that incision that you have made, you are not going to have any of these lasso sutures on top of crossing your incision line. Everything is going to be internal, all right? These sutures are not going to be showing up in your final picture, all right? So that's what we are going to do. What I do nowadays, I don't start with a big suture right in the middle. I start in one of the corners, and then I cross all the way to the other corner, and then I close it, and then I start like going back and forth just to have like the big sausage, like Istvan Urban, right? Super famous technique, really good technique as well. One thing that Istvan Urban does, it's using text, right? To do the sausage technique. Very nice technique. There's the sequence of the text. But for O6 Plus, it's not that you cannot use text. I just cannot use it. It's quite challenging because I haven't used too many times these texts before. So I'm not very comfortable with it. And the O6 Plus, if you're not very comfortable using text, they're gonna tear. If you're really good on tacking, you can use O6 Plus. You may tear like 1 or 2 times, but after you're gonna get the point, and you can tack. It's not a problem at all. But I cannot do it. It's just more challenging to do it. All right. I'm not good enough on that to do it. So I don't. So I don't do it. But you can. I really recommend to do this lasso technique with O6 Plus and the O6 product, but I don't do the other one, even because I don't like removing the text. So. That was the defect that I was doing. This is just to show you guys a case, clinical illustration of we just talked about it. That's what I said about you can see on the bottom right here, going all over the place. Can you see that there's one crossing everything? That's probably my first one that it's under the other ones. Can you see it? I go to one corner, I cross to the other, I do to the other corner of the graft, and then I keep going back and forth until I feel confident enough that it's pretty stable. So this is how it healed. Can you see that open a little bit? It always opens a little bit. Why? Because I don't do that much periosteal release, because increases mobility. Older patients, they're gonna bleed underneath. I'm gonna have a big ecchymosis here. So that's just bad advertisement for you. A patient walking around looking like they got beat up by their dentist, all right? So I rather have these little amount, this 1-2 millimeters of opening, keep it clean, chlorhexidine on top of it. Nothing else you have to do it. Of course, I give antibiotics just in case. For every patient, even the ones that didn't open, I always give it, but it's not a big deal. This is just to show you guys, sorry about the different resolution, different machines here, but just to show you how we could preserve the whole architecture, even from before the extractions were there. So everything was pretty much the same there. So this is just the conclusion of the case. The kind of implant guide that I like to use. All right, I like to use this one a lot. And this is just a case that I could show you and give you like some tips, especially for whoever it's starting to do implant dentistry, starting to get interested about placing implants. That's the best guide for me, because if you have a guide that guides your drilling process, it's a very nice one, especially for whoever is right in the beginning, doesn't have steady hands yet, it's just nervous. But this one, it's gonna allow you to do little adjustments, because sometimes you open the flap and the bone is not the way you were expected to be. And 80% of the case, it's like that. You have to change a little. So even if you have to change a little bit the apex of the implant, they change a little bit the angulation, you know where your implant should be. Still should be right in the middle of the crown. So you still know where your crown is gonna be, all right? So that with the Masics, it's the best one for me. And of course, if they're like a hard one with a thick material, it's way better. So one thing that I want you guys to look at it, I don't know if you are noticing something in this case, but if you see these two implants that we placed there, they are kind of funky, and you guys are gonna kind of agree with me. So this is just the restoration there, just to show you. But this is what I wanted to show you guys, all right? So I feel pretty comfortable doing that, because now Dentsply and Dates over there, they are married together. So I don't have any problems showing you guys a little bit as soon as we are talking about bone grafts. We can talk about a new concept that it's the graftless, all right? Sometimes you don't have to, instead of going and crazy about grafting techniques, why don't we use like some tools, some ideas for us not to have that much success with grafting. We can find we can meet somewhere in the middle, all right? We can improve a little bit our grafting techniques, and we can use some materials where you don't need that much grafting, which is this one. This one is the slot or the profile EV implant from Dentsply. And it's a very good idea, all right? This is the other edge of intraoral rehabilitation, the challenging one, all right? We are going to improve a lot our bone grafting, but definitely we know that nothing is 100%. And definitely this, it's going to decrease a lot our need of success. Sometimes doing a graft that it's going to be there like 80% of what we are expecting, it's going to be enough because you use a swapped implant, a profile implant, an inclinated implant. Can you see right there? And you don't have to use only in static area. They were developed to be used in the static area where you don't want the implant to show too much on the cervical area. But I started using with slot ridges, all right? And they work just fine in some places. Some patients that they cannot afford doing for ortho, elderly patients, and they just don't want to. So you just have to give them an option, all right? And this is an option sometimes, and they're gonna love it, and they love it. As soon as they're on board, we explain everything to them, and they're on board with that. So let me show you this case. And one tricky thing here, there was accused before. When I did this case, I swear I didn't do this just to have the picture and the comparison. It's just because in the clinic, this was during my perio residency. We only had one profile EV. So here we have a regular one here on the left side of your screen, and we have the profile on the right side. So the profile on the right side, it's actually on the same height, but it's not showing on the buccal because usually the ridge, it's a knife edge, and we have the defect of the ridge on the buccal side, right? The resorption of molars, we lose the buccal plate. And then now we don't have to graft that little thread, because tell me about it. These threads that we always graft, these grafts is not going to take that. We only graft because we are stubborn and we want to do our best. But this graft doesn't take that. There's no potential for bone to grow on top of these threads in the back. We just place something there. And actually the best one to place there is xenograft because it's going to stay there for a long time. So it's just going to be a cushion on top of it. So, but we are not going to have real bone there, all right? Keep that in mind. And we have other, this was actually the first, the main indication for that. So we had this case, let me go back here. So we have a cantilever on number 8, or the left central incisor. The number 8, it's the American way of saying the numbers. And I'm used to that already, but I know that all the rest of the world, we don't use these numbers. So the left central incisor, it's actually a cantilever. So I had to remove the lateral incisor and start working on the central. So the lateral incisor, we went there and we placed this flapless implant. But then I did the measurement and I figured that out, that I could not place a flapless on the right, on the central incisor. And that was a silly mistake of mine because I had to open the flap. So why did I do flapless on the lateral? So whoever it's starting to do these procedures, take your time and see if you can place both of them flapless if you want to go flapless. Just think ahead of time. That was a bad mistake that I made. Not a detrimental one, but was not smart at all. So after I did that, I realized that I would have to do like some GBR, some bone grafting in that side. So I did the bone grafting, I got a punch, then I left that one exposed, and I wanted that cushion. And that's what Lasso gave me, all right? Lasso gave me that amount of stability and that amount of security of exactly where I wanted the flap to be, all right? And that's what you want to have. And that takes me like 5, 10 minutes to do it. It's not a big deal at all right? It doesn't require a lot of technique, a lot of ability to do it, especially if we start using it like right in the front. Of course, doing a second molar back there, it's a little bit more challenging, but it's not a big deal. It may take you a little longer to do it. So we just sutured everything, and I always like to do that, keep like working with the soft tissue around the implant. And then we went there, and then we were able to place a flapless implant right there. The same, like different, a slightly different material. This material is a little soft, but it's still the best material for me to do an implant, right? Because I know where I have to place that implant, all right? Even if I will have to work a little bit more palatal to avoid like a buccal dehiscence of the implant, I always like to use this one. And this is the profile implant. You just go there, can see on the left side, the profile implant is a little bit slopped. So you always have to leave that slopped surface on the buccal, and that's marked by that little mark on our instrument. So this is just an example. One more case, and now I want to show you the power of lasso. All right, how much you can confine inside a membrane, being a secured membrane by this technique. So you open that case, you don't know how you're get that done. You have no idea how an implant is going to get there, but you're already there. There's nothing much you have to do. So you open up the flap, you open up the case, and you go there. You get the heebie-jeebies. And back in the days, what we would do is to place like 4 block grafts. When I started practicing when I started doing this kind of surgeries, it was like 16 years ago already, getting old. And we were like going to the ramus, bilateral, getting like big plates there, big blocks. We were like split it in half, put it like exactly the way they are looking there right now. And we would fill it up with xenograft. That's what we had back there. Or tissue bank. We would get like fresh bone processed, and we would like just process that, and we would use all around these blocks. That was a good technique, and it worked really well. Not very stable because the block graft, they have a tendency to solve and lose volume with time, but still pretty good technique. And for a while we were doing like PRFs. Now things are like slowing down a little bit. I don't see that many people like talking about it anymore. There's nothing new on it. And PRF for me, it's just a really fancy blood clot, which is really good. But you're gonna have like 3 times more platelet than normal because you have a vial of that, and you end up with a little membrane like this. So you have this amount of blood, and you have a membrane like this. Best case scenario is that you have 3 times more concentrated platelets, and 3 times more, it's not that much. Thinking about like, and when we think about all the other like bio agents like PDGF or BMPs or anything, it's way more concentrated than that. So we cannot compare these things with PRF. PRF is really well done, really organized, really fancy blood clot. That it's going to give you something really cool that it's called sticky bone. That you mix it up a little bit with some blood, and you let the process. You go with the injectable PRF and you put it on top of it, and it's going to get this jelly consistency, this sticky bone consistency. Then you put another membrane on top of it, and you can have like this sashimi-like bone graft. You can put it there, and then you start freaking out again because you don't know how we're going to close that up now. You didn't know how to place the implants. Now you kind of have the graft, but you don't know how to close it. And even gets even worse when you have the jumbo membrane that you found, and you can cover everything with one membrane only, but then you don't have the skills. But with lasso, you can put everything together, all right? And everything is going to hold up really well, and you can close your flap, and this is how it's going to feel, all right? Opens up a little bit here and there because it's a very extensive flap with a lot of release and a lot of lip pulling there and everything, but it's going to work just fine. This is a couple cases from a really good doctor from Florida now, guy from Alabama, good friend of mine, great doctor, great surgeon, great guy. I love him a lot. And it's Dr. Taylor, Dr. Chase Taylor. He shared his cases with me, and I thought that they were pretty interesting. And his documentation is pretty complete. Here is just the CTs, and this is the case that he was showing. And he was doing something like this, and he loves these pictures. I don't know why he loves these pictures. And he can stabilize all of that with the lasso technique, looking like this. All right. And he can have this amount of healing. Did he do anything wrong? No, it just happens. All right. It just happens. And this is a great case. It's just not a perfect healing. Can you see the lasso technique holding everything together underneath? If this is a case of mine and I haven't done the lasso technique underneath, I would have lost this case. Nobody would be able to save this case. And Dr. Chase Taylor did, because he did a really, really amazing job with the lasso technique. So he got all the bone that he needed, and he placed a nice implant right there. Look at the amount of bone graft that he got. Even having an implant dehiscence there. Probably a short vestibule, nothing much that we can do about it. Pretty sure that he released the flap a lot, but sometimes just not enough. Things are going to open up. Patients are going to smoke. Patients are going to not respect. They're going to eat whatever they want. They're going to talk like crazy. This is our job. It's to deal with that. And look at the amount of bone that the guy had. All right. This is another case, pretty similar. He opened up, and look what he found. Not very promising, right? So he did the extraction. He did some split ridge, fancy guy, telling you guys, guy's good. And he did the sticky bone again. He loves that. And look how much he secured that thing. He did a lot of going back and forth, all right, with the lasso technique. I don't do as much, but probably he did that because he placed a lot of sticky bone underneath. So he wanted to be like very compact. And he even placed like some PRF membranes on top of it. So look at what he got. A lot of good healing, and everything was even like suture, going on top of his sutures. So this is the amount of suture that you're gonna have. The lasso technique doesn't have to be used only for barrier membrane with O6 plus. What time is it? Okay, I'm gonna rush up a little bit, all right? So we have time for Q&A. I see that some people already sent like something. We can use the O6 volume max as well. Right in the beginning, we were calling that a membrane. It's not a membrane, that it's a scaffold, all right? And it's not 1 to 2 millimeter thick. It's a 2 millimeter thick for sure, all right? It's resistant to degradation when exposed. It doesn't heal as well as O6 plus because it's a soft tissue scaffold, so it's gonna be a little thicker. So the soft tissue is not that passive when it's in contact with O6 plus, but still can be used, and I'm gonna show you where. One thing that it's genius on these materials is that you're gonna have some mineralization of the material. We still don't know how much it's gonna mineralize. It's not very predictable yet, but you can be sure that 1/3 of the thickness that you're gonna place there, it's gonna be mineralized, and you're gonna have bone there. So I'm not gonna go for all the processes and all the biology behind it. I'm not the most qualified to do that. All the guys from O6 and from Dayton, they can explain that to you, or you can read that like in 2 minutes. All right. So that's what I did. Look at the upper left picture. We have a little soft tissue defect there, almost like a lack of Kg there. So I wanted to improve both. I did bone grafting with an O6 volume max, not with O6 plus, and the lasso technique on top of it. All right. So that's what I got after. When I opened the flap, I could still see the O6 volume max there. All right. You should not remove it. You should not remove it. Of course, if you have to place your implants, you're going to scrape a little bit where you're going to place your implant, but leave it there. We already know that O6 Volumex takes a long time to show their final results. Even after like 2-3 years after you place that product there, it's still gonna be mineralized and it's still gonna be forming bone. So just leave it alone and let it do the thing. This is one bone graft that I did. It's just to show it's not a lasso technique, but it's just for me to show you guys how these things are gonna heal and how you should expect them to heal. So this is what usually people show, right? And you would believe completely that this heals like that, but it doesn't. All right. The way that healed was like this. And that's why I like to show all of these cases. This is real life cases. This is not like the best case of the month. This is not the best case of the week. This is like interesting cases that I have documented, and these are not the perfect ones. Even the ones I show from my friends, they are not the perfect ones, and they have a lot of perfect cases that I could use. This is not the point here. What I want to show you guys, it's what you should expect. Even if you have a little problem like that, when the patient comes back 2 weeks later or 1 week later, and we see something like that, you get a little concerned. You are concerned that the patient may be in pain. You run your fingers, you see if there's pus here and there, and there's nothing. You just have to let it heal. Be patient and let it heal. All right, that's what you're gonna find. This is just to show the images that we have bone there and we have a good contact. We don't have to see that. Yeah, I just have to show. I'm just stubborn to show everything. This is a good concept. All right, from Gustavo Avila Ortiz. I got to know him back in Michigan, and the guy is one of the best that I have been studying with, actually. Right now, he's in a completely different level. I still follow whatever he does because the guy is super nice and incredibly intelligent. So he defined the difference between membrane and scaffold. Scaffolds, it's going to be a 3D structure that supports the tissue and allow the tissue to grow inside and outside and right next to it. All right, basically like that. Membranes are barriers only, and they are not going to allow anything to grow inside. The O6 Plus mineralizes, but it's very thin. It's not going to make that much difference in your final results. But yes, on scaffold, it's kind of thick, and you can fold that membrane in 2 or even 3 times, and you're going to have some bone formation there. This is a case that I want to show you guys, probably to finish up what we have here, so we don't extend too much. This is a case that I got published because it was an interesting case, a very interesting case. I got this case, and the patient had a hard extraction because she told me it was pretty hard. The dentist had a hard time, and I really believe it was pretty hard. First molars are a nightmare. All right, some of them are terrible. They're just like, you believe that they're ankylosed and nothing moves there. You just have to keep digging. The septum goes away. It's a nightmare. It's just a bad day in the office. All right, and we have to remove them, and we pray for the best. When I opened, I had this lingual defect there. All right, and a lingual defect, it's terrible. Poor guy that extracted these two because he lost the lingual plate because probably he was having a super hard time removing these two. But I end up like with that defect, and we know how challenging could be placing bone graft there. The particles and doing the lasso, and the bone particles would be all over the place. And if my assistant moves a little bit on that lingual and the tongue touches, and it's gonna be a mess. I was just like not feeling good about it. But then we have O6 Volumex, and I folded the O6 Volumex in 2, and I placed there without any bone graft. I just placed the O6 Volumex, and because I believe the concept, and I had to trust the concept that would help me out in this situation. And I did as much periosteal release, as much lingual flap release that I could, and that's what I got. Everything healed pretty well. And this is at one time point, and this is by the day that I was opening up the surgery again. And this is what I got. The lingual defect was not there anymore. And I did not use bone graft. That was just the O6 Volumax. All right. Probably I didn't pay much attention in the soft tissue, but I'm pretty sure that the soft tissue was way thicker. That was not the case that we actually needed. I really needed bone desperately, so I wouldn't have like a lingual dehiscence of my implant. That would be terrible. All right. And I was able to place the implant in the right position. I didn't have to place any more buckle. I didn't have to improvise anything, to place like a narrower one on a molar that wouldn't be the ideal. I was just there. And this is just to show you guys that I did not have the defect anymore. All right. The defect, the lingual defect was not there anymore. It was all flush with the rest of the teeth. And this is the before and after. Let me see. This is just from the paper. Yeah, that's just from the paper. And let me see what else we have here, so we can minimize a little bit. I have other cases, but I think we are gonna pack things up here so we can go for your questions. If I have to go back in one of the cases here to make a point to answer the questions, I will. All right. So let's go for the Q&A here. Let's see how we are going to.
Just a second, Dr. Silva. There are a few things I would like to do with your permission before the Q&A. All right. So let me share my screen again. Just a second. All right. I believe that everybody can see my screen right now, isn't it? Right. So, yeah. First of all, thank you so very much, Dr. Silva, for this lecture. Before we'll go to the Q&A, I would like to ask everybody here to fill out the webinar survey, which can be accessed either by scanning the QR code on screen, or you can see it also in the chat pane as well. It's there right now. Please dedicate only 2 minutes to fill it out for future improvements. Your opinion is highly important to us and we really appreciate it. For US clinicians, at the end of the survey, there is a link for the CE evaluation as well. There are some question polls which are on screen right now. Please feel free to answer them if you like. And I would also like to inform everybody of our next event. So Dr. Silva will be back for his second lecture. This is the first out of 3, as mentioned at the beginning of this webinar. So Dr. Silva will be back for his second lecture on July the 19th. And the third part will be on August the 16th. You can use the QR code on screen right now to register yourself and to join it. I would also like to inform everybody here for our next events. So this week on June 23rd, Dr. Stephen Jacobs will be here. On July 1st, Dr. Jay Goldberg will join us, and on July 7th, Professor Ami Schmidt will also be joining us for his lecture. And these are for the actual lectures. All right, and now as promised, here's the link to your feedback. So thanks again for that. And now, Dr. Silva, sorry, please go over the questions. Many questions are here waiting for you from the audience. So be my guest. Thank you.
So okay, let's go for the questions here. I find it hard to release this periosteum around the lateral and canine upper. Okay. I find loss of muscle fibers and it looks like a mess. All right. All right. Can we go back there?
The questions are there for you.
Oh, let me just put it. Oh, I just put it on the side here. Thank you.
Right. All right.
So, yeah, I can answer that. It's just a challenging area for you to do it, especially the patients that they have a shallow vestibule there, because they're gonna be right there on the nasal fossa. And yes, there's a lot of muscle attachments there, but it's just a thing that we have to deal with that. It's just a challenging area to do it. Yes, it is. But as much as you can minimize that periosteal release that I told you, not doing like not using the scalpel, overuse the scalpel, we are going to minimize a lot of swelling and a lot of ecchymosis and hematomas in this area. All right. Just be careful with, just be gentle with this area. Where does the lingual or palatal insert for the lasso suture to keep inside flat? All right. Sorry, I didn't mention that. Good point. Good question. You get the periosteal pouch, remember from that little video on the pig jaw, and then you are gonna raise the lingual flap. You're gonna go as apical as possible on the lingual flap. You go in and out. You're gonna get it on the lingual flap, and you're gonna go back in, like 2-3 millimeters on the side, right next to it, and you're gonna go back in, and as apical as possible. All right. So you're gonna still gonna have a mobile flap on top of that. You don't go right next to the flap. You go as low as possible, so you're gonna have a good shape of your graft around your mandible. You're gonna embrace your graft around the mandible. All right. Let's see. Did the dehiscent heal on its own? Not on its own. We clean it a little bit, but even if you don't want to clean much, it's gonna heal on its own because the tissue affinity of the ossix membrane, it's incredible. It's a pretty good. I'm a big fan. You'll see that it's gonna diminish your headaches by 90% in your office. All right. It doesn't adhere bacteria. It doesn't. The tissues, they don't respond to it. They don't get inflamed. They don't get away from the membrane. They just grow on top of the membrane. Of course, some irrigation. It's prudent to do it, and maybe some chlorhexidine. Just put it in there, just for us to feel better. I don't know much if there's a big difference. What's the indication for Volumex as opposed to Ossix Plus? Okay, the next webinar that I'm gonna do, I'm gonna show that difference very clearly. All right, I have more cases to show with Ossix Volumex, and I'm gonna show it. But basically, when I feel a need of a better soft tissue there, I go for that. Or if I see that the defect is too big, that a thicker soft tissue would help me out with that defect, because it's not much about how much bone you place. You can put a ton of bone there. It's about the potential of regeneration of that site, the shape of the defect, the age of the patient, the site that you are grafting. You don't grow bone like vertically any way you want it. So it's not too much about the amount of bone that you place. It's about how much bone the body can form. So any help from the soft tissue would be beneficial. Then I use the Ossix Volumex. All right. You mentioned the relationship between membranes and scaffolds. Can you also discuss the relationship of membranes and scaffolds and their classification of osteoinductivity and osteoconductivity? Unfortunately, we don't have an osteoinductivity yet. All right. That would be like a really nice material that would be embedded in BMPs or something like that. Super expensive, probably, because BMPs infuse it, so crazy expensive. But osteoconductivity, definitely, bone grows inside the Ossix Volumex, inside the scaffold, and the Ossix Plus actually mineralized. The first one that I helped on the research project in 2008 did not mineralize. Had a really good barrier function, a really good tissue affinity, but it did not mineralize. After they figured out a way for the osteocytes grow inside a membrane. I have never seen anything like that. But if you see one of these slides that I skipped, that I went through, you can find everything. If you want, I can share that with you, or I can show a little bit better if you want on the next webinar. Just remind me of that. But there's a lot of histological evidence, and they show a lot of new bone formation inside the scaffold, inside Ossix Volumex. That's not new for us at all. That's not a challenge for them anymore. All right. So yeah, also conductivity, definitely. That's a really nice thing. So if a material like that can go bone inside, I'm not worried about the tissue affinity of that material, the biocompatibility. All right. The lingual side without bone activation, the lingual side. Yeah, I think bone activation, maybe the activation of the lingual plate, like doing the perforations, maybe that's what you're talking about. No, I don't do it. I don't do it on the lingual because the access, it's just too hard to get. Yeah, I don't do it. But I don't graft too much on the lingual side. Maybe you're asking about that lingual defect that I just published. Maybe that one, but even that one, I did not do it. I don't do pretty often. It's just too hard to get there. The drilling like spinning too fast on that area. Usually I use high speed to do that because the burrs are like thinner for the high speed. And no, I'm not taking the chances of going there and poking that. If that gets trapped in my flap, it's a mess. I don't like the idea. I don't think it's worth it. When you place the Volumax no graphic material for the lingual defect, did you do any cortical perforation first or just place it over existing cortical plate? Just placed over. All right. Maybe the perforations could help, or we just don't know yet. Or nobody was interested enough to figure that out. Maybe it's a good research project. How long after did you go back into to place the implant? This is for lingual defect treated with Volumax. Thanks. Probably 3 4 months, 3 months and some. But we wait at least 3 months. That was just protocol. And nothing. You don't have to wait any longer than regular graft to go back in. Usually it's 3 months and some. We will respect three. After 3 months, then patient starts like scheduling. Sometimes it's a couple weeks later because of scheduling, and that's it. What type of sutures do you use? Resorbable sutures for lasso, for the internal sutures for sure. Bipool, it's enough, and PTFE sutures on the surface, on the regular ones. I like PTFE. How do you stabilize O6 Volumax on lingual flap? Your paper case. Lasso technique, same thing that we were talking about, nothing fancy. Where can I find the recording? They're gonna send it to you. In lingual lasso techniques, have you encountered lingual nerve damage? Oh no, not at all. You have to be very like unlucky to hit the nerve. I put the and the same height. I don't go vertical on it. So I go in and out, and right next to it, same height, right on the side, I go back in. No, never got that. In the last case, after how long was the re-entry for hip replacement done? 3 months, 3 and some. How long do you wait after putting O6 Volumax? Well, you have to you wait a little bit, all right, 3 4 months, but keep it in mind that you can have better results if you wait a little longer. I'm gonna show in the next webinar pretty interesting cases that you're gonna be very impressed of with what O6 Volumax can form in terms of bone. How do you select bone graft, autograft, xenograft combination? Basically, xenograft, it's going to stay there forever. Anywhere that I want my implant to be placed, I go for allograft, not autograft. Autograft, I don't harvest bone from there anymore, unless I need a very little one. So I get like a back action scalpel chisel, and then I just get some bone and I just pack there, so I don't have to waste a whole vial of bone just because of a couple millimeters to cover a thread of an implant or something. But not much. Hi, Dr. Silv. Could you please explain the suture sequence in lasso techniques? This cross suture. Some advices, thanks. Yeah, that I will have to start all over again, but I can definitely go over any other time soon. But that's pretty much what we talked about the whole lecture today. All right, so I cannot just in one question to give like a summary of what we talked here for more than 1 hour. So I can definitely go over that with you, or you can just get the paper, send me an email, or message me on Instagram. It's my name on Instagram, Fred Silva DDS. Send me a direct message. I can send you the paper, and there's a pretty good idea of how to do that. All right, guys.
And that was the last question, Dr. Silva.
Lots of fun. Have a good day for you guys that are like early in the morning. You go to sleep, buddy, because it's in the middle of the night for you in Tel Aviv. Get some rest, and let's make it a good week. It's still Monday here, and let's keep it up.
So with that, I would like to thank you, Dr. Silva, for your time, efforts, and professional input. And I would like to thank also everybody here for joining us. And I hope to see you all in our next events. Thank you again, Dr. Silva. Thank you again, everybody, and have a great day.